which will be Neil Desai, who will talk about targeting the tumor microenvironment. So maybe you will find some answers to your questions here in this presentation.
I'm not going to say anything about stem cells, unfortunately. Thank you for the organizers for inviting me. Today, I'd like to talk about the cancer stroma related to the microenvironment and how we can target it. We don't, of course, have all the answers yet, but we do find that some interesting data and findings in relation to targeting the stroma. So just as a general point, we use nanomedicine for a lot of things, and in general we talk about overcoming biological barriers. There's many barriers that we can overcome, like absorption in the gut. We talk about RAS avoidance, possibly pulmonary adsorption, the blood-brain barrier, transdermal absorption, getting into the tumors and taking care of the high interstitial fluid pressure, the endothelial barrier. We heard some talk about that today, and the tumor stroma. So I'm going to focus really on the last two here, endothelial barrier and the tumor stroma, and talk to you a little bit about the drug that I have worked on, which is Abraxis or nab-paclitaxel. So most of you are probably familiar with this drug. It was approved in 2005, first in breast cancer, and then following more recently in lung cancer, and now we have some positive data in pancreatic cancer and in melanoma. And it's a nanoparticle made with albumin and paclitaxel, and you can see some pictures of the cryo-TEM. It's about 130 nanometers in size. And the type of data that got us looking really into the mechanisms of this drug was our early clinical data, when we first saw that you would have patients that did not respond to standard paclitaxel, which is the cremophore paclitaxel or Taxol. But then when they're treated with Abraxis or nab-paclitaxel, you see quite a dramatic response. So clearly there's something different going on, the same active ingredient, but the drug is more effective or effective on the tumor when the conventional paclitaxel is not. Other early data that we saw was, for example, in pancreatic cancer. Here's a patient with here's both CT and PET imaging, and you can see extensive metastases here in by CT and as well as CT PET. And following a couple of cycles of treatment, you see a big reduction in the metastatic burden, and both in CT and PET. So these are the type of the clinical data that drove us to study the mechanism of the drug. And a lot of that relies on the properties of albumin. Albumin is, of course, a ubiquitous protein in our body, but for a long time sort of relatively unrecognized in terms of its function, except for its oncotic pressure maintenance. But it's a very important carrier of many different molecules. It's evolved to carry molecules. It's basically a transport molecule. And nab-paclitaxel therefore utilizes these pathways that are available for albumin. We know that tumors have a high metabolic uptake of albumin that's been published. And more recently, very interestingly, along the same lines, there's been some data showing that RAS mutated cells actually have a high uptake of albumin because of their energy dependence on glutamine. So this is just published data showing high uptake of gadolinium-labeled albumin into a tumor. This is in a mouse model. You can see, in fact, the same type of occurrence in a human tumor, and this is a human glioblastoma, and labeled with a fluorescent dye. The purpose of this experiment is really to help the surgeon to remove the margins of the tumor during glioblastoma surgery. And so this is administered to the patient, say, 24 hours before the surgery, and then visualized under fluorescent light, and it results in very good removal of the tumor during surgery. So the mechanisms of transport. First, we'll talk about the endothelial cell. And the albumin binds receptors on the endothelial cell of blood vessels called the GP60 or albondin receptor, and that triggers the formation of caveolar processes, which are cause transcytosis, which means transport from the blood lumen side into the interstitium. And in this case, this is the interstitium of the tumor. So you trigger the formation of these caveolae, and the albumin-bound drug gets transported through the caveolae and through the endothelial cell into the interstitium of the tumor. So this is an active transport process, not a passive transport, and can work against a pressure gradient. This has been demonstrated very nicely in some papers where you have gold-labeled albumin, and there's amazing pictures here of TEM of the endothelial cell where you see these gold-labeled particles starting to form the endocytic vesicles here, and in fact some of these vesicles making it all the way across and depositing their contents to the abluminal side. And this is exactly what we believe occurs with nab-paclitaxel, and we've published some data showing transport of nab-paclitaxel being about 4 times higher than the conventional paclitaxel across endothelial cells. So as far as RAS mutations and cancer, clearly there's many different types of cancer that have RAS mutations, but the one that we're most interested in is in fact the one with the highest rate of RAS type mutations, mostly KRAS. It's about 60% in pancreatic cancer. And now we begin to understand some of the clinical results that we're seeing in relation to this. So there was also a very recent paper published on how RAS mutations affect the transport of albumin into the tumor cell. So once it gets past the endothelial barrier, which I showed you in the earlier slide, the question is how does it internalize into the tumor cell? So macropinocytosis is highly upregulated in these RAS-transformed cells. And these RAS-transformed cells, of course, are highly dependent on glutamine as an energy source, and the best source of glutamine they have is, in fact, albumin. And there's been data shown that if you inhibit this macropinocytic uptake of the protein, then you, in fact, inhibit the proliferation of these cells. And so here's an example of pancreatic cancer cells and another prostate-type cancer cell. You can see the marker that's used is a TMR dextran, which is a micropinocytosis marker, and you can clearly see that here much higher in the pancreatic cells. And in fact, compared to the non-transformed cells, the pancreatic cells show 8-fold higher uptake. And once again here, if you use FITC-BSA along with the TMR dextran, you can see the merged picture shows you that these two co-localize both in this cell type as well as the pancreatic cancer cell type, which are both RAS mutated. So here's another mechanism and understanding of how transport occurs into these pancreatic cancer cells. And you had Professor Barinholtz talk earlier today, and he was saying that he had all these notes that he put down where he would think about solving those problems later on. The research always goes on. No matter, you have an approved drug, it doesn't stop. So these are things we're still discovering, 7, 8, 9 years after the drug has been approved. So talking about the stroma now, the characteristics of many different cancer types are different, but stroma is an important component of the cancer and its microenvironment. In particular, in pancreatic cancer, is known to have very dense stroma, highly fibrotic type stroma. There's many different cell types within the stroma that are either immunological type cells or fibroblastic type cells that have been activated. And there's a lot of collagen present, as can be seen in these histology pictures. There's not a very high concentration of blood vessels. So clearly drug delivery to these type of cancers would be a challenge. And the question is, can you use some mode of drug delivery that in fact can overcome these barriers? This is also some published data on pancreatic cancer development, and you can see from the normal on the left side, as you progress into more invasive cancer, you can see the progression of the collagen increase and the stromal fibrosis increase, and also activation of the alpha smooth muscle actin, which is really an indication that your fibroblasts or pancreatic stellate cells are becoming activated myofibroblasts. This is published data again of showing poor perfusion both by CT and PET of pancreas, pancreatic cancer. And so this is well recognized that these tumors are poorly perfused and drug delivery is a problem. So this is some interesting data, and some of you may have seen this before, but when we take human-derived pancreatic cancer xenografts and grow them up in the mice and treat them with different drugs. Here you have a control which looks a highly fibrotic type tumor, which you expect. But when you treat with nab-paclitaxel, the architecture of the tumor has changed. You're losing some of these fibrotic collagen type stromal components. If you treat with gemcitabine, which is a standard of care in pancreatic cancer, which is the drug that's been approved for pancreatic cancer, it doesn't change the architecture of the tumor. It looks very much like the control. But however, if you treat with a combination of nab-paclitaxel plus gemcitabine or the nab-paclitaxel alone, you're changing the architecture of this tumor. So there's something going on that's depleting or destroying the stroma. And this correlates with the response of the tumor in the animals. If we measure the drug concentration in the tumor, in this case we measured gemcitabine that was taken in combination with nab-paclitaxel. This is prior to, this is with gemcitabine alone treatment, so this is, in this case, you have a certain level of gemcitabine getting into the tumor, but if you treat with the combination, you actually increase the gemcitabine concentration in the tumor almost threefold. So by some mechanism, you are destroying the stroma, you're increasing the drug delivery into the tumor, and therefore probably increasing the improving the outcomes. This has been shown also in another case of another drug, which is a hedgehog inhibitor, IPI 926. And in the same type of study that we did, here's the control staining for collagen. You have gemcitabine alone in pancreatic cancer. You have IPI alone, and you see the difference in the architecture of these tumors, and here's the combination. And in this case, they measured perfusion of doxorubicin by fluorescence directly into the tumor, and you could see that with these combinations and with IPI alone, you could increase the level of drug delivery into the tumor. So this concept is sort of holds good. If you're able to destroy some of these stromal components, you're able to increase drug delivery into the tumor. Lastly, we sort of translated or tried to translate this into the clinical setting. We did a pilot study in resectable pancreatic cancer. So the purpose was, these are early stage pancreatic cancer patients who are treated with neoadjuvant nab-paclitaxel plus gemcitabine and then go to surgery. So they do the Whipple and they remove the pancreas. So we have an opportunity to take the tumor sample before and after the surgery. And there were 16 patients entered into this trial, and here's the results of the treatment. 3 of them had progressive disease, so they did not respond to therapy. And there were one did not go to surgery because he had some heart comorbidity. 12 of them went to surgery. Of the 12, you had 10 patients that had adenocarcinoma, and 2 of them were actually neuroendocrine tumors of the pancreas. So the 10 that were treated with the combination of nab-paclitaxel and gemcitabine, out of them, 1 had a complete response, so complete disappearance of the tumor. You had 6 that had a major partial response. So you had 7 responding patients, 1 with a minor response, and then 2 with no response. So this overall was a very good result. When we looked at the architecture of the tumors, it was very interesting. This is untreated, this is prior to treatment. You can see this is staining for collagen. You can see organized collagen fibrils. The middle panel is actually looking at another set of patients who were conventionally treated with chemo and radiotherapy. And these patients still retain that architecture of collagen. However, when you treat with the nab-paclitaxel, this group of patients, you see a sort of disintegration of the fibrillar structure of collagen, similar to what we saw in the animals. If you look at SPARC staining, SPARC is an albumin-binding protein that is also secreted in tumors and also in pancreatic cancer. This is prior to treatment. This is in 2 patients. You can see heavy SPARC staining, and post-treatment, the SPARC disappears, indicating that somehow treatment with nab-paclitaxel has targeted these cells, and these cells no longer exist. Anecdotally, what's very interesting, if you look at CD31, which is looking for neovasculature in these tumors, it's almost absent in the pancreatic cancer, which you expect and is known because they're poorly perfused. But you start to get CD31 staining coming back in the post-treatment samples. So somehow you're stimulating some circulation into the tumor, and which could also possibly help drug delivery post-treatment. If you look at alpha SMA, which is a marker of activated fibroblasts and myofibroblasts, you see pre-treatment heavily stained, no treatment was also heavily stained. This is the conventional radiotherapy and chemotherapy. This stays, and then after nab-paclitaxel treatment, you've sort of destroyed that component as well. So in general, these are the outcomes you see upon treatment, and this leads to better drug delivery and outcomes in the patients. And there was an interesting publication recently looking at tumor stroma and its components and how destroying some of those components could in fact result in better drug delivery. And this was the model they had proposed, and it's very interesting to see that our histology looks very similar to what was proposed in that model. So with that, I'd like to end, and I thank you all for your patience.
Yeah, thanks a lot for clarifying the critical role of tumor stroma. Questions? Simo, please.
Do you have any hypothesis why this is happening? What's the mechanism of action that might destroy the stroma?
Well, we know it's getting into the tumor. The possible mechanisms by which it's getting into the tumor is one, especially in pancreas tumors, is due to RAS mutated cells having an affinity for albumin. And those things are being studied right now, the exact mechanism of that. But we do know that they have a high uptake of albumin. So somehow it's getting there. And then possibly the endothelial cells, although, pancreatic tumors are not very vascular, but they're somehow, making it through. So we're getting drug delivery. The exact mechanism is quasi-understood. We maybe know a few components of it. We certainly don't know all the components.
Yeah, 140 nanometer particle would not penetrate that deeply into most tumors. I don't know whether pancreatic tumors are more permeable than that. So does the particle fall apart in the bloodstream, and you then have albumin with barren paclitaxel? And then the second question would be, do you have any idea about dosimetry? How much paclitaxel is actually being delivered of the injected dose?
So to answer your first question, we have already established that the mechanism of transport is dependent on the particle coming apart, which happens rapidly. So we measured that, in the lab. And then the circulating species is albumin-bound paclitaxel, and that's what binds the receptors and gets transported. So that's you're correct in that respect. On the percent of injected dose, we haven't specifically looked at actual quantification of how much of it makes it into the tumor, but we do have sort of comparative data versus, for example, standard paclitaxel with Cremophor, and we published that. So we get, at the same dose, you get 33% higher amount of drug getting into the tumor at 24 hours.
Last question.
Congratulations, really excellent data. Did you measure the survival rate from the 16 patients you gave the nab-paclitaxel albumin-coated nanoparticle formulation?
So this is still early. These are resectable patients, so they usually have a much better prognosis than the metastatic patients. So these data were just of this year. So these patients are probably still surviving. So, but we have, of course, a lot of data on metastatic cancer patients in terms of survival.
Okay, then thank you again, Neil.